I placed the incision quite high because I want it to be splinted by the remaining cartilage. And I could make this obviously a little bit shorter, but by having it away from where their glasses hit, this graft has not been a problem. No one's complained yet of it showing. There are usually 3 or 4 blood vessels along the way. You can use a needle tip cautery if you want to, and we'll dissect this with the tenotomy scissors. And it's pretty straightforward. It's just a couple spreads in either direction just to open things up. It's critical to be feeling the top of the conchal bowl and to go under it. So I'm just I want a fairly big graft today. We're now ready to go ahead and take out as much of the conchal bowl as we can. I'll cut right along here. We're really going for maximum cartilage today. But basically, we now have some cartilage that we're going to be able to make her bridge out of. This is the superficial fascia, and this is the deep temporal fascia that you want. Now I'm going to go ahead and I'll divide the superficial, and that opens up the incision, and we've managed to avoid the vessels. Now, when I do the dissection, what I'm going to do is I'm going to clear an area, and this is a very easy space to open up widely. We're going to start with the endoscope, and here you can see a pretty broad view. I'm going to go back 3-4 centimeters and make a cut through the fascia and bring it on around. We're making our cut about 3 to 4 centimeters back on either side because the fascia shrinks so quickly. Now I'll make the cut back and just getting through the fascia, not going deep. Then I can take my Ragnell retractor and just slip it in to pull the fascia forward. And you can see that we're just taking a tremendous amount of fascia here. We can take a sheet 10 to 15 centimeters almost when you think of things about how broad it is. Relax just a little bit there. We're going to be completing the inferior portion of the dissection and removing the fascia. And you can see what was 10 centimeters or so across inside the temporal area really does contract significantly. So we have to harvest a lot of fascia to have an impact in the nose. So at this point, we'll go ahead, I'll take the stapler, and we'll begin closing the wound. What is different about this approach is I'm trying to defat the thick, soft tissue envelope. And this is, to me, a fairly unique way of doing it. What I'm going to do is make the standard infracartilaginous incisions and then dissect as subcutaneously as I can, leaving the soft tissue on the alars. What I don't like is that idea of peeling the skin back and defatting against the vascular arcade. What you can see here is I'm going to be dissecting very much right at the level as subcutaneously as I can. I don't want to injure the dermis, but basically I want to leave every bit of fat, anterior, posterior, nasal dilators on the alar cartilages. I want to thin out this envelope in a safe way. I switch over my scissors at this point away from the little Converse scissors, and you see I'm not in any way going to have to dissect against the skin. Now, at this point, I can go ahead and bring up the soft tissue, and you'll see that we really have thinned this skin, I think, in a very safe way. I can't imagine any kind of vascular problems in the overlying skin until it happens, of course. But we're peeling this over. I always try and leave all the soft tissue in the columella. I don't try to dissect right against cartilage over the tip area. Now, this is just absolutely typically Asian. Start exposing the septum from a top-down indone position. And this is a little more challenging, but I think it's a very useful way of preserving the membranous septum to keep your graft where you want it. We'll take a peek now at the septal exposure. I think you can see we've got mucosa up quite well on both sides. I don't see any tears in the mucosa. And we'll go ahead and we'll harvest now. You can see where the scrapes were made. This will be I'm going to try and leave about an 8 to 10 millimeter strut. I'm cutting parallel to the true caudal border of the septum. So often people bring it too anteriorly and go across the nasal spine area. Now I'm going to parallel her dorsum with the dorsal cut. And I may even get a little bone because we're going to need every bit of cartilage that we can get. Then I'm going to come down along her vomer and really try and disarticulate this thing completely along the vomer. And she's coming up very well. And in fact, I think we can probably bring her out right now. We're now ready to insert our septal lengthening graft. What I've got to do it with, though, is just an absolutely wonderful piece of vomerian or perpendicular plate of ethmoid. And I've drilled 4 holes, here, 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 and here, using a K-wire and a striker. I'm just going to drop that in, and this graft, hopefully, if we take this out now for a minute, is just going to look like it was planned for this purpose all along. And this will keep her from being depressed on her tip when she smiles. Of course, the fun part, of course, is finding these little holes. And I'm just going to fix her with some 5-0 PDS here, and then go ahead and lengthen her. And then we'll suture through again, and we'll advance the alers onto this, using this as both a septal lengthening and a columellar strut. We'll keep a fairly generous tail on, or medium length tail on this one. Here you can see we've got some pretty good support. We'll go ahead and we'll cut that. This is one of the huge advantages of dice cartilage grafts. While I've been doing the nose and putting in the spreader grafts, the strut grafts, and doing the tip, the circulating nurse has put on some sterile gloves and prepared these syringes of dice cartilage. So instead of having for the surgeon to spend 45 minutes to an hour shaping a cartilage graft to put down the bridge or putting in some kind of delicate K-wire, this has been done for me. So it takes about 5 minutes for me to do a dorsal graft, and that's one of the huge advantages of dice cartilage. Now I want to show you two little tricks. One is people always want to know how fine should the dice cartilage be. And what we now call the injection test, if I take this, you can see that I can just inject this perfect stream of dice cartilage. So if it won't come out of the syringe, then it's not fine enough. Now, the second is, what do you do if you have some air pockets in there? And so you'll see that you can always put this graft in and then inject, and the air comes out the syringe and you compact your dice cartilage so that you can really have this extremely compacted. So again, it's important to compact the cartilage before you inject it. We know that fascia survives very nicely in the wounds based on biopsies during follow-up surgery, and so I'm just kind of getting this trimmed out. Now this extra fascia we may end up putting over her tip cartilage to keep everything smooth, but I think you can see that this is going to be a very nice container. Now my assistant's going to hold the grid down. I'm going to take a 4-chromic on a small needle, and we're just going to run the cartilage, run the suture down the fascia. Now, I like this to be a locking suture. Now, my assistant's going to follow me, and we're going to just lock this as we go down the side of the graft. The next step is to put some percutaneous sutures in to guide the upper part of the graft. And here you can see I've got a little straight needle on a 4-0 plane, and I'm just going through the graft, and I'm just going to, this also closes what in this case will be the upper end of the graft. And here you can see we'll just do one and then the other. I'm going to show you how to make a uniform dice cartilage and fascia graft. This is a type of graft that is used in major dorsal deficiencies, 5, 8 millimeters in height, or in many Asian rhinoplasties. And so what you want to do is just to slip this syringe in and then just inject on the way out. And you can just see the massive nature of how much cartilage. This is a full syringe. And then you can obviously taper it and even produce a little bit of a natural dorsal curvature as you come down. So what has happened because of dice cartilage and fascia is that we've ushered in a new era in dorsal grafts. We can now make these grafts to measure, and we truly have the ability to do a designer dorsum. I'm going to go ahead and do the alar rim graft. I prefer to make a transverse incision inferiorly. Some people, like Gyron, prefer it higher. I prefer it down there. Then I take the tenotomy scissors and just dissect superiorly along the edge of the rim through the skin where there was no alar cartilage. Remember, she was very retracted. And then down so that I can back my graft down that way. And then I'll just take the conchal cartilage. We'll just slide it right up the pocket. And then once we get it in, we can back it down and see how happy we are. And I'm pretty happy. I may want to weaken it just a little bit. I'm definitely going to I'm going to take just a little bit of that off so that it doesn't evert. These are really oftentimes very three-dimensional type effect. So you don't want it to be too strong. And then I'm going to close it up with some 4-chromic, and then I'm going to go back and check the other nostril, see how symmetrical, more symmetrical I can get things. So at this point we'll be ready to start the closure, to start inserting the doyle splints and putting on the cast.